Leicester, looking at falls prevention and decaffeination. If you could make sure that you are indeed on mute if you aren't presenting or speaking, that would be enormously welcome. My name is George Appleton and I'm the Head of Policy here at Care England, but I'm fortunate enough to be joined by Sarah Coombs, a continence nurse specialist at University Hospitals of Leicester, who'll be leading the vast majority of today's webinar. In essence, today's session is really aimed at trying to increase the awareness of decaffeination and the array of benefits it can present to your organisation. So, to provide some context, as part of Continence Awareness Week, University Hospitals of Leicester's NHS Trust's Adult Continence Team launched a challenge whereby the Continence Team worked collaboratively with ward staff and housekeepers in Leicester's hospitals to promote and offer decaffeinated tea and coffee to inpatients across the trust. I'll let Sarah talk through all of this in more detail, but the potential benefits of switching to decaffeinated products in any environment, and in this particular context, adult social care settings, could be significant and include improving a person's health and potentially reducing falls, as well as improving service user dignity through the use of lower continence pad usage, for example. I personally was first introduced to this initiative during the all-party parliamentary group for bladder and bowel continence care back in November of last year, wherein Sarah gave a presentation on the benefits of decaffeination, and it became very apparent to me very quickly the potential benefits for adult social care providers. So fast forward a couple of months and we're now here, and I'm absolutely delighted that Sarah will be delivering this presentation and introducing you all to hopefully what you'll all deem to be a really pragmatic way of not just improving health outcomes, but also wider benefits such as cost savings as well. So I'll conclude my little preamble with some small pieces of housekeeping. So this webinar is being recorded. This is so we can share the recording with not only yourselves here today, but also those colleagues who were not able to join us for one reason or another. Today's session will last an hour, and Sarah will be talking us through a collection of slides to provide an overview of her work and the benefits to care providers of decaffeination for the first 30 minutes or so, whilst the second half of the meeting will be really handing over to you, the audience, to ask Sarah any questions you may have after her presentation has concluded. The chat function is available to you all, so please do add any questions here for Sarah throughout the duration of her presentation, and I'll flag those retrospectively to her at the end of her presentation. But I'd also encourage you to use the raise hand function following the conclusion of her presentation if you feel your question or point would be better articulated in that way. There will also be a virtual poll at the end of the presentation and the session in its entirety to garner some feedback from members. So I'd be really grateful if you could stick around until the end to respond to this poll, as this will help inform as Care England, our next steps in relation to this particular initiative. So I think that covers everything at this moment in time. So at this point, I'll pass over to Sarah to take us through the next 30 minutes, and then you'll hear from me again when I reintroduce the Q&A session. So Sarah, over to you. Sarah, you're on mute, just as a heads up. If you unmute yourself, then we can begin the presentation.
Okay, can you hear me all now? Give me a nod.
Yeah, brilliant,
Perfect.
Sarah. Thank you very much.
Hello, everybody. It's a wonderful delight to be talking to you all today about a fantastic project which we launched in our hospital trust just over a year ago called Taste the Difference Challenge. And my name is Sarah Coombs. I'm a continence nurse specialist for one of the largest acute hospital trusts in the country. And I work with both inpatients and outpatients. But in my previous role, I also worked in the community as a continence nurse. So I have been in care homes, I have done continence assessments. So I've got a very good perspective as a continence nurse, both in an acute and primary care setting. Okay, so the Taste the Difference Challenge was launched in our trust just over a year ago, and it resulted in an organisational change with decaffeinated tea and coffee served as the default option, which saw an 80% reduction in falls occurring specifically on the way to the toilet. The aim of the session, next slide, thank you, is hopefully to inspire you to promote the benefit of decaffeinated tea and coffee to care home residents, and to see decaffeinated tea and coffee not only served, but also served as the default option. Slide 3. Thank you. I hope to inspire you today, and I'm going to be going through what the Taste the Difference Challenge is, how caffeine can affect the bladder and its link with falls, some of the other health benefits of switching to decaffeinated, and hopefully get you to think about how you might want to implement your own Taste the Difference challenge or decaffeination in your own care homes. Next slide. So what is the Taste the Difference challenge? Essentially, it's a very simple idea that involves introducing decaffeinated tea and coffee to your residents, educating about the benefits, particularly in relation to a more healthier bladder and potentially reducing the risk of falls, and then asking for some feedback as to A, whether the person can taste the difference, and B, whether they would switch to decaf once they've heard the health benefits. It's a quick win project that involves a very small change that can make a big impact. Slide 5. Now, feedback to the challenge is key. You need feedback from your residents to implement an organisational change. So when a person tries a decaffeinated drink, they fill in a simple feedback form, which you can see in the slide attached. You collate the data, which is hopefully positive, and then you use this data to present a case for change to suggest a switch to serving decaffeinated tea and coffee as the default option, with caffeinated tea and coffee served on request. Next slide. The idea for this project evolved as part of a project to promote harm-free care in our hospital trust. And in our hospital, there are 3 hospitals in our trust, and 1 in 4 patient falls are related to toileting, and that's roughly 350 last year. And there is research to suggest a high correlation between falls occurring and lower urinary tract symptoms. My task as a continence nurse specialist was to think about, from a continence perspective, what could be done to reduce falls related to toileting. And I noticed from doing observations on the wards that whilst decaffeinated tea and coffee was available on the tea trolley, patients weren't always aware of this and it was never offered. So what's the big deal with caffeine and how may this be linked with a resident having a fall? Next slide. So caffeine, there's lots of positive benefits. It's a natural stimulant found in both tea and coffee. It stimulates the brain and central nervous system and can make people feel more alert and less tired, which is great for a Monday morning. The British Dietetic Association reports that drinking roughly 300 grams of caffeine a day, that's roughly 3 mugs of coffee, is a safe volume to consume. However, for an older person with an overactive bladder, such as urinary urgency or frequency, research suggests that a small amount of caffeine can make bladder symptoms worse. So in one study involving 1,100 patients aged over 60 years of age, half of the group found that drinking 3 mugs of caffeine a day resulted in an overactive bladder. A third of the group who drank less than 3 cups of coffee a day still experienced an overactive bladder, and severe symptoms were experienced by 10% of this population with drinking less than 3 cups of coffee a day. So there is research to suggest that caffeine can affect an aging bladder. So how does caffeine affect the bladder and how is this linked to falls? Next slide. So caffeine found in normal tea and coffee is considered a mild diuretic, which means it can, 1, increase the production of urine in the kidneys. 2, it's a stimulant. Caffeine is a stimulant and it stimulates the detrusor smooth muscle, which is the main bladder muscle, which is responsible for contracting and excreting urine. And 3, it lowers the threshold of the bladder filling phase. But all in all, drinking caffeinated tea and coffee can result in an older person needing to wee more often, pass urine more urgently when the bladder is irritated, causing rushing to the toilet, and therefore potentially increasing the risk of having a fall. And this should be a concern because as care providers, we know that falls are common in older people. Next slide. Just some statistics which you may be aware of. A third of people aged over the age of 65 fall at least once a year. 1 in 2 of those over 80 years fall at least once per year. And it's the most common cause of death from injury in the over 65s. It costs the NHS 2 billion a year and over 400 million bed days. And people living in care homes are three times more likely to fall than in their own home. Switching to decaf could help to reduce these falls and save lives. Next slide. Other ways in which switching to decaffeinated tea and coffee could reduce falls. So we've mentioned that it's a stimulant, and caffeine can cause sleep disturbance and insomnia. So by cutting out the caffeine and switching to decaffeinated, it can improve an older person's sleep. So why is this important? We know that an older person is at a greater risk of having a fall at night when it's dark, and they may be more unsteady on their feet or feel disorientated. High doses of caffeine may also affect the absorption of calcium, which is linked to osteoporosis. If there is a loss of bone strength, it can increase the risk of a bone fracture, particularly after a fall. And falls are not a normal part of aging. They can be prevented, and our goal should be to promote good health and introduce simple strategies to reduce risks of falls occurring, such as switching to decaf. Next slide. Okay, so some other health benefits of switching to decaf. Caffeine can affect the heart. It can increase blood pressure, cause tachycardia, which is an increase in the heart rate, and cause heart palpitations. It can also prevent dehydration and headaches by switching to decaf. A lot of caffeine can irritate the bowel. Caffeine can speed up the peristalsis, which is the muscle contractions in the digestive tract, and can move food along quicker. So caffeine can act as like a laxative and cause diarrhea. Switching to decaf can also reduce indigestion, as caffeine can increase the production of stomach acid that causes this. Thank you. Okay, next slide. So switching to decaf is also an opportunity for care homes to promote continence. We know that at least 50% of care home residents have urinary incontinence. If residents are incontinent of urine, they're likely to be wearing a continence pad, and they could develop moisture-associated skin damage. And it's estimated that the NHS spends £80 million per year annually on pad usage. Incontinence is not an inevitable part of ageing. We should be looking at strategies to try to improve a person's continence and not just look to manage it with pads. Continence can be improved by simple lifestyle strategies, such as switching to decaffeinated tea and coffee, which can potentially reduce incontinence, pad usage, and improve skin integrity. So now I've provided you with an understanding of how caffeine can affect the bladder, explain the health benefits of switching to decaf, and the links between caffeine and falls. I'm going to return to the Taste the Difference challenge, which we delivered in our hospital trust, and the results. Next slide. Okay. So this Taste the Difference challenge was implemented over a week as part of Continence Awareness Week, and 699 patients took part, which meant they tried a decaffeinated tea or coffee, and they filled in a patient feedback form when they tried the decaffeinated drink. So what we found from this data was that half of our patients couldn't taste the difference between decaffeinated tea and coffee, and that 3/4 of our patients said they were switched to decaffeinated tea and coffee having heard the health benefits. Do you want to go to the next slide? So this last part is really important and it's really interesting. So patients may prefer the taste of caffeinated tea and coffee, just regular tea and coffee, but patient feedback suggests that once they've heard the health benefits, switching to decaffeinated tea and coffee is more important. So the education is really important. So with the evidence that roughly 75% of that population would prefer to switch to decaf, a recommendation was then made to our hospital executive team to serve decaf tea and coffee as the default option, and within 6 months I'm pleased to say that this was implemented across our whole trust, which is 3 hospitals. And it's important to emphasise that caffeinated tea and coffee is still available on request, but otherwise, if a patient asks for tea and coffee, they're served decaffeinated automatically. So if we fast forward a year, has switching to decaffeinated tea and coffee reduced the number of falls occurring specifically on the way to the toilet in our hospital? Next slide. Yes, it has. So if we look at our data, for before we commenced the Taste the Difference Challenge back in 2020, it shows the number of falls that are occurring each month, specifically on the way to the toilet or the bathroom. When caffeinated tea and coffee was served as the default option, we were experiencing sometimes up to 27 falls per month. And following the introduction of decaffeinated tea and coffee as the default option, this figure has dropped to as low as 4 per month, which is an 80% reduction throughout 2021 and 22, which is really impressive. Next slide. So apart from looking at the impact of decaffeinated tea and coffee on falls reduction, we've been trying to measure out other outcomes. So we've been looking at our outpatient clinic, where we see patients with bladder and bowel problems. Looking specifically on bladder problems, we ask patients whether they've noticed an improvement in reduction in urinary urgency since switching to decaffeinated, and 63% of our patients said that they have noticed a difference, which is really good. Following the implementation of decaf with our inpatient ward, one month afterwards, our healthcare assistant went to all of our wards, spoke to the housekeepers and ward staff, and she got some really good feedback. So out of our 90 wards in our hospitals, 85 were serving decaf as the default option. There were 5 housekeepers who chose not to serve decaf, and it appeared so that they were doing so out of their own sort of personal preference for caffeine, which indicated that some education was still needed. But apart from this, patients reported that they couldn't taste the difference. Interestingly, in accident and emergency, the staff were reporting that patients were sleeping better, so less agitated, and also large numbers of staff were switching to decaf once they were made aware of the health benefits too. Okay, next slide. So if we're going to switch to decaf or think about cutting down or stopping, we do need to mention caffeine withdrawal, as it is a potential side effect of serving decaffeinated as a default option. So it's important to have a management plan for this. When we first implemented decaf, we had a very small number of patients that reported some withdrawal symptoms. I think it was 6, I think in 1 month. The withdrawal symptoms to be aware of include headaches, fatigue, low energy, irritability, anxiety, poor concentration, a lower mood and tremors. If a resident experiences any withdrawal symptoms which are bothersome for them, they have 3 choices. They can either stay stopped and encouraged to drink water, take regular analgesia such as paracetamol if they are experiencing headaches. They can switch back to caffeine if it's their choice, if they don't want to stop. Or for residents that want to aim towards cessation but are struggling with the caffeine withdrawal, we just suggest a gradual reduction process, such as cutting down by 1 cup of caffeine a day, and then look to stopping after drinking about 5 cups of tea or coffee a week. Okay, next slide. Okay, so hopefully I've inspired you all now to try a Taste the Difference challenge, or just implementing decaffeinated tea and coffee into your care homes for residents to try. I'm just going to suggest a few ideas to think about before you do this. So maybe look at your falls data. So what is the prevalence of residents having falls related to toileting, specifically in care homes? This may not be data that you capture specifically. You may not theme your falls, but maybe this is something that you want to look at. How many falls are related to toileting? If you have a number of care homes to manage, maybe consider focusing on the care home with the highest prevalence of falls related to toileting initially, to pilot a project to see how you get on with that. To consider the cost. So there may be a cost implication of purchasing decaffeinated tea and coffee in bulk. So for us, though decaffeinated coffee in bulk was more costly, this was balanced by the savings made by purchasing decaffeinated tea in bulk instead. And cost needs to be considered and weighed up in relation to other savings that aren't financial, such as positive impact on quality of life, prevention of hospital admission due to falls, pad reduction, healthier skin from patients not being incontinent due to a switch to decaf, and education. So it's really important that the staff understand why you want to introduce decaffeinated, because they may not like the taste of decaffeinated themselves, but it's really important that they understand the health benefits so they can support the project with the residents. And it may be that you try a taste the difference challenge with staff just to get them engaged, so you can provide the education in a fun way. So as part of the Taste the Difference challenge, I did design some resources which are available to the care homes free of charge. They'll be emailed out to you, which include posters, a resident feedback form, there are education leaflets. So if you are interested in taking part, you can let us know. I think there'll be a poll at the end of this presentation. Mental capacity. So for residents lacking mental capacity, it's important to talk to family members about their loved ones' preferences for caffeinated or decaf, but to provide the families with education about the health benefits of switching to decaffeinated, so that they can make an informed decision about what's best for their loved one. Do you need to have any resident feedback to implement an organisational change in your care home? In our trust, we had 699 pieces of feedback and 370 was required. So it's just something to think about. And also, lastly, I would suggest, if possible, to have a decaf champion in the care home, somebody that's really interested in the project, that wants to promote it and really champion it with the staff and residents and loved ones too. So, next slide. There's one more slide, then I'm going to show you a patient video. So in summary, why should care homes introduce decaffeinated tea and coffee as the default option? So firstly, it can reduce falls, specifically occurring on the way to the toilet. It can improve bladder health. There are lots of health benefits. It can improve your residents' quality of life. Your residents probably won't taste the difference. And what we know is that our patients, so your residents potentially would want to switch to decaf because of the health benefits. It's also very easy to implement and it could potentially save lives. So before I show you the last slide, which is the patient video, I just want to get you to think about whether you would implement a Taste the Difference challenge, having heard all of this information, the evidence, patient stories that you're about to hear. And I look forward to your questions at the end of the presentation. Thank you very much.
Hello, my name is Paula. I was advised to start drinking decaffeinated tea about 6 months ago. I used to drink normal tea, at least 6 cups a day, and I was having problems with my bladder. I was having to wear pull-ups. I was so constantly wetting myself all the time. Since changing my tea bags, I'm no longer wetting myself.
Okay, I have a MS problem and bladder problem as well. I was being told by my nurse for decaffeinated tea or coffee, which I have started that, and it does help me by not going to rush to the toilet. I used to fall in the toilets when I was not drinking decaffeinated tea, coffee. After I started It was better. It was good for me. I don't have to rush that much.
My name's Steve Wilson. I suffer from multiple sclerosis and I was diagnosed in 2010. Before that, I used to have lots of teas and coffees, and then it was highlighted that decaffeinated tea or coffee could help with my bladder. So as a result of having decaf tea or coffee, it has really helped. There's no urgency sometimes to go to the toilet.
Hi, my name's Lorraine. I suffered from bladder urgency. I changed from caffeinated to decaffeinated tea, coffee, and soft drinks, and have to say that the results have been outstanding.
Hi, my name's Sarah. Now, I've got multiple sclerosis, which I've had about 10 years now. It's a condition that causes me to have a very overactive bladder, and I've tried lots of different medications for it. The nurses suggested that I try decaf, which I always thought it wouldn't do anything, or that it was going to be disgusting, and I was like, I love tea. Yorkshire tea is where it's at. So I was quite dubious about trying it, but I did, and I noticed that I was getting a lot more time before I needed to go to the toilet. I wasn't overactive. With work, I was able to take calls and not have to go in between the calls constantly. It really saved me with running and things like that as well. I used to struggle a lot when I was out running, and that was never an issue. Before my run, I'd have a morning cup of tea and then I wouldn't struggle afterwards. I feel so much better with my bladder now in terms of drinking decaf tea. Thank you.
Thank you very much indeed, Sarah. And I think that was really insightful and some really helpful information there. And there's clearly a host of benefits for care providers. But at this point, it's really over to you in the audience to ask Sarah any questions, either via the chat function. I can see a few questions have already come through. So Sarah, I'll start with those, or please do feel free to use the raise hand function. But if I start off with some of the questions in the chat, first up from Charlotte, in terms of during this trial approach, Sarah, how did your team interact or have conversations with the individuals within the hospital settings to help them decide to switch to decaffeinated coffee or tea? What do those conversations look like, and how do those conversations go?
So how the conversations happened were mostly between the housekeepers and the patient. So let me think. I think 2 weeks before we introduced the Taste the Difference Challenge, we spoke to every housekeeper across the trust. We provided them with a resource pack which included the education about the benefits of switching to decaf. So when, as part of the challenge, when the patient was trying a decaffeinated drink, the housekeeper would inform them. And on the patient feedback form, it does say switching to decaf can improve your bladder health. If you know that, would you consider switching to decaf? So on the patient feedback form, there is a bit of education on there as well, before the person makes the decision whether they would want to switch to decaf or not. Yeah. And
just on that point, and this is another question from Charlotte, what were some of the reasons that you saw why people may be hesitant to make that switch, and how can, whether it's care staff, hospital staff, support people to try and see the benefits in decaffeination?
So some of the barriers, I would say, would be concerned that the taste wouldn't be very good. I think that's one of the biggest barriers, and one of the biggest barriers as well to the staff supporting the project. For the housekeepers that didn't implement it on the ward, and there are still some housekeepers that haven't done that, actually, I've got to be honest. We do keep going back, and it's around their own, I think, personal preference for caffeine. So it's just about sort of reiterating the health benefits, the evidence in our hospital that it has had a positive impact on falls reduction. Other barriers, so apart from the taste, I think the taste is the main one, really. Not that it came from our hospital trust, but I have had questions before about the decaffeination process. So sometimes when tea and coffee is decaffeinated, it can use solvents, to remove the caffeine. So there may be a bit of concern about that, but that's not something I've heard within our trust.
No,
I think I've heard that once in our outpatient clinic. For people that do a lot of research in decaffeination, but yeah, I think it's mainly to do with the taste.
Thank you very much, Sarah. In terms of, well, a lot of the sort of predominant focus of the presentation was on older adults, but for some of our members who potentially run younger adult services, so services for people aged between the ages of 16 and 65, for example, who may suffer from a learning disability or autism, would you say that this initiative is applicable within those settings as well? And how does the results differ for those individuals compared to those who are quote unquote older or in sort of older residential care homes, so to speak?
So I would say that for anyone with an overactive bladder, regardless of whether they've got a learning disability or not, switching to decaf is a positive thing, because the caffeine can stimulate the bladder whether you have autism or not.
Fantastic.
Okay.
Yeah. I follow you.
Yeah.
No, fantastic. Jackie, you put a question into the chat. I'm afraid I'm not too sure what the abbreviation HK stands for. So Jackie, I'm going to bring you in as I can see you on the screen. Do you want to come in and speak to that particular point?
Sorry, I was just, when you said there were still 5 housekeepers, so HK was housekeepers, sorry, that were refusing to offer decaf as, as the default. I was a little bit confused because if that's the hospital policy, surely they're employed by the hospital, that is what they should be doing. I think if being a provider, that would be something that if we were working to, we would expect people to comply with. So I was a bit confused about that really, and why that isn't being perhaps tackled a little bit more.
One of the wards is a renal transplant ward. So obviously after the patient's had a transplant, they want the patient to pass urine. So they would see caffeine as a way to increase the urine production for them to pass urine quicker. That was one of the reasons. Yeah, it's a very good question. Yeah, it's something that we're working on. I mean, one of the wards is the renal transplant. Another ward is actually a gynecology ward. I think some of the ward managers struggle with the idea of it being served as a default option, because now we're only serving it. If a patient asks for tea and coffee, we're serving decaffeinated automatically. But I think possibly some of the ward managers feel that we're taking away patient's choice. But caffeinated is available on the trolley. I think that's part of it.
Thank you very much, Sarah. Yeah, and I'll come to you next.
Thanks, George. Hi, Sarah. I just wanted to know whether you see people kind of trying a combination of decaf and caffeinated drinks, whether they might have a caffeinated coffee in the morning, but then switching to decaffeinated hot drinks for the rest of the day, and whether there's still some benefit in a reduction in the amount of caffeine as opposed to cutting it out entirely.
Absolutely. I mean, we certainly have, if I give an example, so in our clinic, we have a lot of Parkinson's patients, and they feel that having a cup of coffee in the morning helps them to have that energy just to get going. And certainly you may want to specifically think about cutting out, if you're going to just do a reduction rather than a cutting out completely, possibly just cut out at night time and early evening, just so you're giving your bladder some time to sort of excrete that caffeine really before bedtime, so the patient's not awake at night from having that caffeine in the evening. So I definitely think, yeah, a reduction is an option if stopping isn't something that the person wants to do altogether. But they may benefit from having a cup of coffee themselves, just to give them that bit of energy in the morning.
Thank you very much, Sarah.
Yeah.
Another question which has just come through in terms of a lot of adult social care services, they deal with individuals with dementia. What's the interaction been like between those who, for example, lack capacity, for example, in this particular case, dementia, and making informed decisions about caffeination or decaffeination? Is that something which typically goes through families? Is that something which you use best interest decisions to make? Just curious to understand that process and unpick that process a bit more, I suppose.
That's a really good question. Obviously, we have a lot of patients in the hospital with dementia, and when patients first come into hospital, we don't always know their preferences. We do a sort of an individual assessment with the patient with dementia that we will contact the family member to be a part of to find out things like, you know, decaffeination and other things, other preferences that the person may have. But we wouldn't necessarily have that straight away. So in the first instance, when they are coming into hospital, they will be served decaffeinated. And if that changed after we did the assessment alongside the family, then we would obviously serve them with caffeine.
It's a really helpful comment, Sarah. That's really helpful indeed. I think that's all the questions I can see for the time being. So just in the interim, whilst people have a think about any further questions they want to ask Sarah, and as today's session draws to a close, I'd like to ask my colleague to instigate the poll I referred to at the start of the webinar to gather any feedback. So this poll, hopefully, as and when it appears, should span 2 questions, primarily about whether or not you would consider introducing decaffeinated options as the default option within your care services, and whether you'd be happy for Care England to follow up with you in relation to this initiative. So the latter really relates to the fact that we're very keen to track any of you who did want to implement this initiative or change, so we can try and monitor any further progress or outcomes which have been made as a result. But if that whole functionality is struggling to instigate in itself, then we can obviously take further questions as and when people have them, but I'll pause there for a few moments just to allow that poll function to come through or any further questions to rear their heads. Whilst my colleagues try to get the poll function working then, as I can see, no further questions are coming through, and we can always follow up with the poll question as we have all of your contact information and can see those who have indeed. There we go. There are the polls in the chat. So just perhaps whilst I speak, people can look at filling those polls in. At this point, I want to draw today's session to a close then, and as people choose to complete the poll questions or not, I'd first like to thank Sarah for her time. Charlotte, I can see you want to bring it in. You want to bring yourself in. So potentially whilst people complete the polls, please do feel free to come in. Charlie.
Thanks, George. Yeah, just a really quick one. We are obviously running quite a robust events calendar currently, and we want to make sure that our webinars are the types of things that our members want. So we've got a Survey Monkey link to for members to fill out if they've got any suggestions, anything that they would like to see any webinars on in the future to fill in. We want to kind of make sure that we're delivering what our members want.
Thank you very much, Charlie. That's a useful suggestion, doing my job for me in terms of chairing the session. But I first like to thank Sarah for her time and her expertise, which has been warmly received and incredibly welcome. I do hope everyone is leaving today having learned something new and potentially with a new desire to consider implementing such an initiative within your care service or services. I'd also like to thank audience members for your time attending today's session. I'm conscious of how busy you all are, so hopefully you found today's session helpful and managed to take something positive away. For those who expressed an interest in implementing such an initiative, either I or a colleague will be in touch after the webinar, but all of you will receive a recording of the webinar as well as a collection of materials that Sarah referred to and has produced in case you consider implementing this initiative, along with the wider webinar materials such as the slides. If you do have any questions after the session, please do get in contact with a member of the Care England team or Sarah herself, and I'm sure we would each be delighted to assist you in any way possible in relation to this particular initiative. But at that point, I'll conclude and say thank you all very much, and I hope you enjoy the remainder of your day.